Yeah, okay. Let me just. Okay, well, welcome everyone to our study initiation training for the Lyme Meningitis Study. This is the third of the last of the training sessions that we'll be doing. Next slide, please. Please make sure to click on the link in the chat so we can capture everyone's attendance for this call. Please also let us know in the chat if you have any problems accessing this link. We use the attendance log as part of our training documentation. We just want to make sure we give everyone credit for attending this last training call today. Next slide. We do again have a full agenda today. Presenters include our study PIs, Drs. Negrovich and Chen, our DCC program director, Heather Grames, data managers, Bethany Fuller and Tessa Stafford, and the DCC project managers, Brenna Morrison and myself. We'll cover everything from a 30,000-foot level overview of the study to understanding and interpreting Lyme tests and really diving into the workflow. And then in the end, we'll also go over REDCap training and query manager training. We do have a very short break planned for about 1:40 p.m. and we do plan to wrap it up at 3 o'clock Eastern time. And with that, Lise, I'm going to just hand it over to you for your part.
Thanks for getting started. Sorry for the technical troubles. Thank you all for joining. We're not going to take the time to do attendance. I love getting to know everyone and what sites you're from, but the training is pretty packed, and so, but please feel free to jump in if you have any questions or comments or thoughts as you get closer to starting the study at each of your sites. We want to hear from you, but we're also conscious of your times. So this is the 30,000-foot view of the study. Why are we doing this study and how did we get to where we are? So go ahead with the next slide. So I'd like to take a moment to think about and remember Aris, who was the lead and the collaborator to get this project where we are now. And all the good work that we're doing is part of the way we can remember him. And as Tom will say, this is extremely important to his family and his children who are following this work really closely. So we take this time to remember Aris. Next slide. So again, why is this an important question? So the IDSA tick-borne illness guideline was actually first released in 2006. And it said that children and adults with Lyme meningitis should be treated with ceftriaxone. But ceftriaxone, particularly in children, is a complicated therapy. The 2 to 3 weeks, often given at home, requires the placement of indwelling lines like PICC lines. And when we did a study, this was with Amy Thompson, who's the DuPont site PI, looking at children treated with Lyme meningitis with ceftriaxone. 1/3 had complications, mostly related to the placement of the PICC. In addition, some had problems with their antibiotics and reactions. So doxycycline is a second-line therapy. In this time period, there are adult randomized controlled trials done looking at ceftriaxone versus doxycycline, which showed similar outcomes. However, they were small and they were not powered to look at small symptom differences. There is one center in the US, as I don't know if anyone's on from Pittsburgh, but several years ago, the Pittsburgh decided based on the available evidence that they would treat all children first line with doxycycline. And they published their findings in 2019 of 38 children successfully treated with Lyme meningitis. Was that someone from Pittsburgh? But in any case, those children treated in Pittsburgh did well. Great. Oh, thank you. Welcome. So there's sort of growing evidence that doxycycline might be a considered second line. Next slide, please. So with that background of two therapies, Aris led a trial in the Hasbro ED, the RIH ED, where he asked parents waiting whether they'd be willing to participate in a randomized trial of doxycycline versus ceftriaxone for the treatment of Lyme meningitis. After they watched a video, They were asked a series of questions. One of them would be they be willing to participate, and interestingly, a large percent at that time would have been willing. And we also asked some questions around how many more days of symptoms would families be willing to tolerate in order to avoid a long-term IV. And this ended up feeding into the non-inferiority margin that we used for the current trial, which, as you know, is not a randomized trial. So go on to the next slide. So despite the IDSA guideline from 2006, which stood until last year, practice is changing quickly. And so we looked at pediatric hospitals and children treated with Lyme meningitis, including 24 centers. And we identified over a 5-year period, 239 children with Lyme meningitis. And in the first year, 2016, as far as we could tell, was about half and half, getting ceftriaxone and doxycycline. But by the end of our study period, which was 2020, the majority of children were actually receiving doxycycline rather than ceftriaxone for therapy. So only 9% were treated with ceftriaxone. And I know a lot of you have seen that at your site where there's been a very rapid change in practice. Next slide. So the IDSA guideline was officially released at the end of 2020, first month of 2021. And it's a collaboration of many people, including, and I underlined here, Sunil, who's one of the site PIs, was one of the panelists, and I had a role as well. Next slide, move forward. So the PICO, or the study question that's most relevant here, is what are the preferred antibiotic regimens for the treatment of acute neurologic manifestations of Lyme disease without parenchymal involvement of the brain or spinal cord? That is, how do you treat patients with Lyme meningitis? And I'll just read the key sentence here, which is, in patients with Lyme-associated meningitis, cranial neuropathy, radiculopathy, or with other peripheral nervous system manifestations, we recommend using intravenous IV ceftriaxone, cefotaxime, Pen-G, or oral doxycycline. So this represents a change with this last guideline, saying that either the IV therapy or the oral therapy are alternate first-line therapies. So next slide. So in this setting where we know practice is changing, and now the official guideline that many people turn to decide how to treat patients with Lyme meningitis say that either are effective therapy, we have the following aims to our study. And our study is the first aim is to compare oral doxycycline to intravenous ceftriaxone for the treatment of Lyme meningitis on both short-term recovery and long-term quality of life. So aim 1 is to look at the short-term recovery, and aim 2 to look at long-term quality of life, which for this study is defined at 6 months. And we hypothesize, based on the available evidence, is that doxycycline is not inferior to ceftriaxone for short and long-term outcomes. And our third aim is the more qualitative aim, which is to look at patient, parent, and clinician preferences to inform shared decision-making about Lyme meningitis treatments. And we hypothesize that most patients and parents will prefer oral doxycycline based on the ease of administration with better side effect profile. To address these questions, we need to include 250 participants, and that's based on our estimate of the percentage of patients that are going to be receiving ceftriaxone. Interestingly, when we started planning this study many decades ago, not decades, years ago, we really thought most patients would be getting ceftriaxone and a few would be getting doxycycline. Now we're in another situation, so we hope we get enough patients with ceftriaxone. And our estimates are that it'll take 4.5 years to enroll that full number of patients. Next slide. Fortunately, we have 20 great enrollment sites located in Lyme endemic regions. And I'm not going to name the sites, but 8 of them are in New England, 9 of them are in the Mid-Atlantic region, and 3 are in the upper Midwest. And I've laid the location of those sites on a Lyme disease map to show how the sites that are participating are in regions of Lyme disease endemicity. Next slide. Okay, this is a reminder of our primary outcome. So the adult studies didn't have a standardized clinical outcome to say that the patients are getting better. So along the way, we decided to make a standardized outcome measure using expert consensus or Delphi methods. And I just show it here. It was created with 24 Lyme disease experts who treat children and adults with neurologic Lyme disease. We had sort of an organized 4-round process, and we ended up coming up with this tool. And the symptoms that feed into the tool are the severity of the headache, the severity of the neck pain, the presence or absence of fever, sensitivity to light, and problems with the vision. And as you can see, there's sort of mostly yes/no answers. And for the symptoms, they're sort of mild to severe. And we're going to be looking for resolution of the symptoms using this score. Presence or absence of facial palsy, which some patients will have, is going to be looked at separately. Next slide. So this is just a timeline to remind, we're right at the beginning. We're hoping to start enrollment very soon. But we've been working at this for a long time. So prior to 2015, there was a lot of planning and thinking about this. In order to sort of formally study this, we received a planning grant in R34, which was first submitted in June of 2016, resubmitted in June of 2017, and not awarded to September of 2018. And that R34 funded some of the work around the primary outcome measure, the survey of parents in the emergency room, et cetera. We first submitted the R01 for the comparative effectiveness trial in June of 2019, resubmitted in June of 2020. We received the positive funding notice in September of 2021. And with Aris's death, we had to transfer the grant, and that led to some delays. And so it was reissued in May of 2021. So we're just getting started, and we had our first, we opened for enrollment in Boston in June of 2022 and had our first patient enrolled on July 1, 2022. So it's a long process. We're 7 years in and we're just starting. So kind of a look back to look forward. Go ahead to the next slide. So just in conclusion, big picture why we're doing this, Lyme meningitis treatment is changing quickly. Doxycycline is clearly easier to administer than ceftriaxone, but we don't really know in a rigorous way that the outcomes are the same for doxycycline as ceftriaxone. And so there's sort of an urgent need to compare outcomes and preferences while the practice is changing to make sure that the children with Lyme meningitis receive the most effective therapy. And that's it. Let's go on to the next slide. So again, just acknowledging Aris, and then very specifically Tom, who's going to be leading a lot of the training today, who stepped up and is the co-lead for this study and is giving great leadership to this project. Of course, the Utah DCC team, and all of you who are doing the hard work to try to start enrolling these patients. Next slide. We're going to move into Lyme test, which is me as well. But before we move into that, I don't know if anyone wants to pause and ask any questions about the overall purpose of the study without getting us too off track. Some of you are new and some of you have been following along for a long time, so this might have been a review as well. All right, well, we'll turn toward understanding Lyme tests. And in some ways, this is really straightforward. In some ways, this is confusing. And I think as we built our CRFs with the DCC, I realized how confusing this could become. So we wanted to take a few moments to just look at Lyme tests. And this is a study of patients with Lyme meningitis. So all of our patients should have Lyme disease. And so what we want to do is make sure everyone is comfortable and interpreting Lyme tests to make sure that all the patients we include and enroll have Lyme disease. So go ahead to the next slide. This just highlights that Lyme tests are negative. This is a billboard. We don't want to enroll anyone who has a negative Lyme test, but it just shows the general confusion around Lyme testing. Next slide. Okay, so early on in the winter, we spent a lot of time getting information from each of your sites about the Lyme disease testing strategy. And there's sort of two types of testing: standardized two-tier testing and modified two-tier testing. And we're going to talk about the two of them. This table shows the sites and what we learned over the winter about the testing protocol in place at each of your participating institutions. So I'm going to talk about the two strategies here. Next slide. Okay, so what is two-tier testing? So two-tier testing is the way that it's been done for 30 years. And the first tier test is typically an EIA test, an enzyme immunoassay. And there's lots of different brands and companies. If your first tier test is positive or equivocal, then it reflexes or sends to a second tier test. And for the standard two-tier testing, the second tier test is an immunoblot, which is an IgM and an IgG component. And those are interpreted by the presence or absence of required bands. And so in the right corner, it talks about if for IgG to be positive, you need 5 out of 10 bands. And for IgM, you need 2 out of 3 bands. And so a person with a positive two-tier test is going to have a positive or equivocal first-tier test, and then a positive immunoblot by the criteria that are listed there. So let's go to the next slide. So we wanted to make this, sort of real in terms of looking at the way the results might look in the computerized system for those that are looking at it. So this is from Boston. We are a Cerner hospital, so the record will look similar for those hospitals that are using Cerner. We use standard two-tier tests, and our first tier test is a whole cell sonica EIA. If a person has the Lyme test sent, then we will see this result, and this 3.74, and it's in red, so you're thinking I need to look at this a little bit more closely. And then there's the text down below that allows you to interpret it. So you see that 1 to 1.2 is equivocal, and 1.2 or greater is positive. So this patient has a positive first tier EIA test. So the laboratory will reflex to an immunoblot, which you're going to see on the next slide. So this is that same patient who reflexes to immunoblot. And you see that there is a positive IgG and IgM. The laboratory has interpreted that for you. And so you know this patient has positive Lyme serology. Next slide. If you hit on the comment button or footnote, you can get the full text. So you can see the specific bands that the patient will have, which, and then, so we know that you have to have 5 out of 10 bands. This patient has 10 out of 10 IgG bands and 2 out of 2 IgM bands, or 2 out of 3 actually IgM bands. And so this patient has positive standard two-tier serology. So this is an example of how it might look for those reviewing. Next slide. So here's an example just of somebody who might be ineligible. This is a patient whose first tier test is 1.12. When you look at the footnote here, you know that 1.12 falls in the equivocal range. So it's going to reflex to an immunoblot. Next slide. And here's the immunoblot for this patient, which shows the same ELISA result. But then for the Western blot, the first is listed as negative for both IgG and IgM. So this patient would not be eligible. Next slide. You can click on the footnote just to confirm, but we have 2 out of 10 IgG bands, so that's not enough to be positive, and none out of the 3 IgM bands. So that just shows you the background, but your system has interpreted for you the overall results of the immunoblot. Next slide. So we wanted to look at this, how this might look in another system. These were shared by the RIH team, and they're another site that's using the standard two-tier, but it's an EPIC-based system, so it looks a little bit different. And also the specific tests that are sent are different. So here's a patient, de-identified patient, whose first year test is shown, and the first is greater than 8, and it's in red. So then again, you read the footnote down below, and the interpretation of 8 is that it is positive. And again, it shows the equivocal and positive range for the specific assay that RIH is using. Go on to the next slide. So you don't need to remember any of the specific numbers, but because that first tier test was positive, it reflexed to a second tier test. And here you see the IgG is positive. And then if you want to look, it gives the specific bands that make it positive. And for IgM, it's also positive. And that it gives you the specific bands that are positive. Go on to the next slide. Okay, so that summarizes the standard two-tier testing, which as of our survey in the winter was approximately 50% of the sites, or maybe even closer to 2/3 of the sites. The other third are using modified two-tier testing, which was approved as an acceptable algorithm testing several years ago by the CDC. And I anticipate over the study period, more and more sites will be using a modified two-tier testing. And that's because the immunoblot, the second tier test of the standard, is kind of awkward to do and a little bit hard to interpret. So there's a lot of movement toward the modified two-tier testing. So what is the modified two-tier testing? It's an ELISA test. If it's positive or equivocal, it's followed up not by an ELISA, but by a secondary, excuse me, not by an immunoblot, but by an ELISA, a secondary test. And one comment that I didn't make on the first graph is that IgM is hard to interpret. And so for those that have been sick greater than 30 days, an IgM alone is not enough to be define Lyme meningitis. But in our acute cases, very few children or none of our children will have been sick for 30 days. So it's a little less applicable. So let's go on to the next slide. CHOP was nice enough to share a screenshot of a positive Lyme modified two-tier serology, which they're using now. And this is, again, an EPIC-based system, so it'll look more familiar. The results here, so this is a first-tier test, and the results is 3.93 for the first-tier ELISA, and you can look at the interpretation, and that's clearly positive. So that's going to reflect to an immunoblot and go on to the second-tier test. I have that on the second slide. Next slide. So that patient would then reflect to a second immunoblot. And as you can see here, the IgM is positive based on the criteria, or it's actually in the equivocal range based on the criteria. But then the IgG, which is the more specific assay, is clearly in the positive range. So this is a patient who has Lyme disease because both their first and second tier EIA tests are positive.
At least you're
slide.
calling it an immunoblot, but it says ELISA.
Yes, this at CHOP, and sorry, my mistake. The modified two-tier testing, the second tier test is ELISA, and that's the real difference. Apologize for my misspeaking, but yes, the second tier is an ELISA. It has both an IgG and an IgM component, but it's an ELISA, and that's why it can be done oftentimes in-house or more quickly, and is not so subjective. Its interpretation is just a number, and that's why I think people are going to favor it going forwards. Next slide, I think, summary slide, no questions. So does anyone have questions about what their site does or how to interpret a Lyme test? I think the key to this is because we have to decide if a patient is eligible, we want to be able to look at Lyme tests and be sure that the patient does have Lyme disease before we ask them whether they want to participate in the study. So it's important both the first and the second tier results are available prior to making that decision. So somebody who has a positive first tier test, but the second tier test is not available, we need to wait before we ask them for consent. We can give them the pre-enrollment information sheet, which we're going to come back to later, but we shouldn't be getting their informed consent. And so that's a key part of this part of the training. Thank you. We can continue to ask Lyme disease questions along the way.
All right, handing it over to Brenna for the study workflow.
Okay, so we are now going to use the study workflow to format the remainder of our training. And I want to thank sites. A lot of you have already sent us your site-specific workflow, so this may not be anything new, but hopefully we'll answer questions some of you may have faced or will be facing as you customize your workflow. Next slide, please. So we're going to start with screening, consent, and eligibility kind of fall into this screening and consent section. Next slide. So the steps listed are from the workflow template, and they will need to be customized to your site. We've highlighted items that should be customized in red. For example, each site will need to identify how they will screen. What tools or logs do you have access to that could be used for screening? Will you screen based on location or on meningitis symptoms, chief complaints, tests ordered, test results, ED clinician referral? You will also want to screen for age. We would also like you to think through the screening hours at your site based on all of your staff schedules. Describe how the RAs or RCs will receive alerts. Will they receive an email alert for patients in the age range that have a Lyme test ordered? Who will follow up on lab results after a patient has left the ED? This section is meant for you to think through where, how, and who will be responsible for screening and finding possibly eligible patients. Next slide. The next step is to document the patient on the screening logs, which need to be documented in 2 places. First, your local screening log. We have provided a REDCap template, which is located in eBinder. This is outside of the Lyme EDC database. You can also use any local screening log that you use for other studies. The second place screening will need to be tracked is in the Lyme study EDC, which is REDCap for this study. Any potentially eligible patients that are screened need to be entered into REDCap. Bethany will go into this during more detail, or go into more detail during the REDCap training a little bit later. Okay, next slide. So if the participant appears eligible for all inclusion and exclusion, and the Lyme test results are known positive, you'll skip to step 4. Next slide. However, if they are not known positive yet, first you'll want to confirm eligibility, obtain the pre-enrollment information sheet, which Lise just mentioned. You'll want to document where you are saving that pre-enrollment information sheet. So you'll gather that from the location you have them saved or stored. These sheets are site specific with your local logo and contact information, so they will not be included in the enrollment packet, which I will show you a little bit later. Think about a plan B in case the research coordinator is unavailable and a treating provider identifies a potentially eligible participant. What steps does your site take in that circumstance? Next slide, please. Confirm the participant meets all eligibility criteria and confirm a clinical team member has informed the patient of their Lyme disease status before approaching for consent. We do not want to be the ones informing them that they have Lyme disease by approaching them about this study. Next, refer to the eligibility worksheet in the enrollment packet where these steps are outlined. On the eligibility worksheet, note any Lyme-related antibiotics the participant is currently prescribed in the EMR. This is done so that you can later confirm the information with the participant and enter it into REDCap. Ask yourself who will identify potential Lyme participants not identified during RC coverage. Provide the process at your site. Next slide. Step 5 is to approach the participant and obtain consent by using the enrollment packet that DCC will provide. The steps for obtaining consent are also different depending if the participant is in the hospital or at home. We will go into more detail in the consent section in just a few minutes. In a nutshell, if the participant is still in the hospital at the time of consent, approach them, proceed with consent, and give the participant or parent the enrollment packet. Next slide. If the participant is not in the hospital at time of consent, the process is slightly different. First, you'll obtain the document of informed consent checklist. This checklist becomes your call log for attempts to call. You'll log the dates and times call attempts were made. You'll want to verify the Lyme meningitis antibiotic on this form. Then email the participant the enrollment packet with a copy of the consent form once verbal consent is obtained. And now Heather will give us a detailed presentation on consent, followed by Tom, who will go through the inclusion and exclusion criteria as well as the enrollment scenarios.
Thanks, Brenna. Like she said, my name is Heather Grames, and I am a program director at the Data Coordinating Center. I work on a bunch of different networks. Many of you might be involved in the PCAR network, which I am a part of as well. I'm just going to kind of go through quickly the consent and assent process, kind of in general, and then more specific to the Lyme study. Next slide. So the first thing to consider when you are starting up this project, this study, is really thinking through your process. Like Brenna said, you want to think through your screening process, but you also want to think through the consent process. How are you going to be communicating with the patient and the family? Are you going to always be in person? Is there a chance that there could be phone or text involved? Who's going to be obtaining consent? Or is it always going to be the coordinator, or do you have clinicians or your site PI who's going to be doing it as well? What if the family doesn't speak English? Do you have translation services? Do they help with research studies? And then how will you track or call patients if they have left the unit? So we talked previously about some of these patients could leave the emergency department or somewhere else before their Lyme tests are resulted. And so you don't know if they're fully eligible yet. And so you're waiting for that Lyme test to be resulted. Make sure you have a plan in place on how you're actually going to do this and what the communication flow is. And then always being prepared on what you should expect when you enter the patient room. Make sure that you know the family's name, the patient's name, why are they in there? Just being really prepared and really making sure that you have everything, all the considerations in place. Next slide. So in some of our other networks, we really talk about informed consent and service excellence in parallel. Informed consent is really a way for you to communicate with patients and families and really talk to them about research in general, and then specifically for the Lyme study. We really want to treat people the way that they want to be treated, and really increase the quality of the consent process. And not only does this help with having them consent into the Lyme study, but also other research activities, or if they are approached or exposed to research in the future, they will have a good experience with the consent process and the Lyme study in general. Next slide. So we kind of have a words that work, or really trying to think through what you're going to say to the patient and the family. A planned communication strategy can serve as a guide for what you say and how you present yourself. The consent document is really helpful in this regard, as it's kind of an outline of all of the study procedures and what the family can expect. So really going through the consent document on your own, before you actually approach a patient, so that consent document, the study procedures, backwards and forwards. Making sure that you're making eye contact and that you're really engaging with the patient and the family. And this is really a way to reduce anxiety, fear, and stress for patients and families. They could have been approached for other studies where they didn't have a very good experience. And so they might be turned off by research, or they might be in a really stressful situation. So just really being prepared so that you can reduce their anxiety. And I know that many of you have probably already consented, tons of patients and families in other research studies. So this is probably just a review for you, but wanted to bring it up. And these slides are accessible. So if you do have more junior coordinators or research associates that don't have a lot of experience in research, really going through this with them would be ideal as well. Next slide. So the tools that we have is we use Icebreaker, remember to relate, and empathize. And I'll go through these in more detail. Next slide. Next slide. Perfect. So Icebreaker, it stands for, the first one is introduction. So like I said before, be prepared for what to expect when you enter the patient's room. Are they going to be crying? Is there going to be stressed parents? Are they pretty calm? Are they asleep? Just be prepared that you could get kind of anything and it runs the gamut. Know the patient, know why their name, know why they're in the ED in the first place, what their plan of care is. So that's really communicating with the treating physician or your site PI who, or the nurses as well. And then create a positive first impression as you enter the room. Make sure to introduce yourself, your role, how you are involved in the study, and just really be open with your body language. Next slide. The C in icebreaker is connected, confident, and conversation. So make a connection to those in the room, make eye contact, be personable and professional, but relaxed, establish rapport. Like I said before, be prepared, know your stuff, know the consent document. And then we've always taught plan your interaction as a conversation in 3 parts. So state the main idea and see if they're even interested in the study. Expand on the details using bullet points, and you can really use the consent document as kind of an outline for how to do this. And then the third, walk through the actual consent document. Next slide. And then the E in icebreaker is for educate. So just always as a reminder, the informed consent, it's not a sales pitch. You're really just sharing information about research so that they can make an informed decision for themselves. And depending on the age of the patient, you're either going to be talking to the actual patient, or you're going to be talking to the parents, or you could be kind of having a combination of both. Making sure you share the information on their level. And again, this is really important for those younger kids that are at the age of ascent, but still need kind of a breakdown of what's actually going to be happening. What is, what is their role? What are they going to be expected to do? And then before you leave the room, make sure you share the next steps. This really helps the parents and the patients with their anxiety about what is my role in the study? Am I going to have to do a ton of stuff? Is it going to take long? What is the duration? How much am I going to be responsible for? Next slide. And then like before, we also use the RELATE acronym. So RELATE is reassure, explain, listen, answer, take action, and express appreciation. And again, this helps in the long run for these patients who, again, they could be approached about a research study in the future. And if they have a good experience with the Lyme study and with the consent process, then they might be more willing to participate in additional research studies in the future. And then also, if you have a really good consent process and they know exactly what they're responsible for and what they're going to be needing to do, then they're more ready and willing to actually complete the study procedures. And this study is a little bit different because a lot of the study procedures are being done by the patient and the parent at home. And we don't have a lot of control on, getting them to answer the surveys or getting them to complete the study procedures. So really making sure that you're prepared and you give them all the information at the time of the consent will hopefully help them to complete more of the study procedures when they're doing it at home. Next slide. And then the third one in work is empathize. So just as a reminder that everyone comes from different backgrounds, has different experiences with research and even in their life in general. So just being aware of culture, though that might affect their decision making, their level of anxiety, any language barriers, and then just as a reminder, we're in research and we kind of sit on the background where we want this certain number of patients enrolled, but we really want to put the consent process at a patient or parent level where, we empathize with them, we know why they're in the ED, and we're really talking to them as a person, not just as another patient that can be consented enrolled in the study. Next slide. And then more specifically to the Lyme Meningitis Study. So as Brenna mentioned before, we do have documents and tools that are available for your use through the consent process. So we have the eligibility form, which is a checklist of all the inclusion and exclusion criteria that you can go through to make sure that the patient is eligible before you approach them for consent. We have the pre-enrollment information sheet. And so this is going to those parents and patients who we don't know if they have a positive Lyme test yet. And so we send them home with this pre-enrollment information sheet so that they know to expect a phone call from us once their tests are resulted. And then, of course, we have the informed consent document that's IRB approved and the assent document. And then a documentation of informed consent checklist, which Brenna mentioned, that will be utilized if you do call them over the phone to obtain verbal consent. And then we have, once they consent to be in the study, we have an enrollment packet, which will be provided to the patients either in person if they're still in the ED or still in the hospital, or over the phone via email, or and it includes the facial droop info sheet, the cling card info sheet, and the outline of study activities. Next slide. So like we mentioned before, there's two forms of the consent process for this study. There's in-person, where you know the Lyme test at the time of screening, and so eligibility criteria can be fully assessed in the ED or hospital. So then you would consent them in person and provide them the information from the enrollment packet, and they would consent in person. And then we also have a verbal consent, where we have IRB approval for a waiver of documentation of consent. So we can call them over the phone if we do not have their Lyme test results, if they're pending at the time of discharge. And then once we find out that the Lyme tests are positive, we have already given them the pre-enrollment information sheet before they left the hospital. And so they know to expect a phone call, and they could potentially be consented over the phone. Next slide. So just to mention about the pre-enrollment information sheet. So this informs the patient and the family that research staff may call them if their Lyme test comes back positive. It can also be given to patients and families by research staff or the clinicians. And if there is potential for it to be given by clinicians in the case where the patient and family are discharged home and you were not able to give them the pre-enrollment information sheet, and the family is waiting for their Lyme test results, there's still an opportunity to introduce a study to the participant and the family. So clinical team members who are calling the patient and family as part of routine care. So if they're calling to discuss their Lyme test results and subsequent treatment, at that time, the clinical team members could introduce the study and say that research staff will send them a pre-enrollment information sheet electronically. And then that gives the research staff the ability to call them and potentially consent them to be in the study. The main idea is that we don't want to cold call any family, so that, you know, their first time they're hearing about the study is when research staff is calling them to consent them in the study. So there is an opportunity to work with your clinical team members and your clinicians if this might happen at your site, and if your clinical team members are willing to introduce the study when they talk to them about their routine care. And again, be prepared for this. If you know this is a possibility at your site, make sure you have a plan in place so that your clinicians can reach out to you and let you know that they introduced the study, and then you can follow up. So just make sure you have a plan in place. Next slide. And then regarding obtaining verbal consent, so the first step is to confirm eligibility criteria, making sure that the Lyme test was obtained within 7 days of phone call and that the patient has not received more than 7 days of antibiotics. Those are both eligibility criteria that definitely need to be marked or checked before you approach them for consent. Then research staff can call the potential participant and family, and then using the documentation of consent checklist. And again, this is provided to you by the DCC, and we can let you know where those all these documents are housed. But use that documentation of consent checklist to document the phone call attempts. We are asking you to make at least 3 phone call attempts. If there's no response and on any of those phone call attempts, then you would still document the patient in REDCap as an eligible patient, but wasn't approached because you were unable to contact. And this information would go into REDCap. And then if you're successful on reaching the parent or the patient, then you would initiate the consent process over the phone. And then just make sure that you, again, know the consent document backwards and forwards so that over the phone you can really engage the participant and the family and answer all their questions. And then if the child's at age of assent, you will have to obtain verbal assent for that child. And this can be done by, asking the parent to put the child on speakerphone so you can talk to the patient, or, whatever's comfortable for the parent and the family on obtaining the assent for the child. Next slide. And then, as you know, we are enrolling a kind of a wide age range in this study, and there is potential for you to enroll patients that are 17 years old who assented into the study but then turn 18 during the study period. And the study period is basically from the time they consent to I think 6 months when their ED chart review is. So if they turn 18 during that time period, then research staff would need to contact the participant to obtain informed consent as an 18-year-old adult. So make sure that you have a process in place if you do enroll a 17-year-old, that when their birthday is, so that you know if you need to reach out to them. And then you would put this documentation of the informed consent process on the reconsenting in the patient study file. Next slide. So in summary, just remember to introduce, connect, and educate, relate, and empathize. There's 2 ways to consent, in person or by phone. Research staff, site PI, co-Is, clinicians can consent participants. Just make sure you know who those people are and that they have adequate training to consent for the study. And then someone has to introduce the study before calling them to consent. So make sure that the pre-enrollment information sheet is provided before the patient is discharged, or make sure you have a plan in place if your clinical team members are going to introduce the study for you. Next slide. And I see a couple comments in the chat, so I'll just look at these. So at some point, can you tell us about the first enrolled patient, where they presented, how they were identified, and how the process went? Who did what, who communicated with who? So maybe in just a minute, we can have Lise or somebody from Lisa's team go through that first patient enrollment. And then a couple questions about the designated age for assent. So the SIRB has not identified an age of assent. It is up to your local IRB guidelines. So a lot of the IRBs that we've worked with have an assent age of 7 or 9. So it would be ideal for you to check your local age of assent, and that is the age that you should use for assenting. What if the child is not at home when you consent the parent? So you can consent the parent and go through the consent process with the parent, and then call back when the patient is available and ready to go through the assent process. You do need to get both assent and consent before you can start any study procedures. And then that would just be documented on the documentation of informed consent checklist. And then at Rhode Island, they said assent age is 8 to 17. So again, check your local IRB guidelines about what the age of assent is at your own institution. Any other questions?
Yeah, so I don't know if Lise or anyone from the Boston team wants to jump in now and talk a little bit about the first enrollment. And just a refresher, if you can't see the chat, it was specifically how they presented, where they presented, how they were identified, and what was the process for enrolling them, who communicated what with who, et cetera.
Thanks, Tom. This is Lise. Specifically in regards to how, just to talk through that enrollment. So the patient we enrolled in Boston,
Lisa, the connection is really bad at the moment. I'm not sure if we want to.
had been diagnosed with Lyme meningitis by their pediatrician. That was one of the enrollment scenarios about symptoms, and why don't we revisit that and just have better signal? Thank you. we'll come back to that. Thank you.
Sounds good. Tom, then I think we're handing it over to you for screening and eligibility.
Great. Thanks everyone for all your hard work on the study. I just wanted to echo something that Lise said. Lise and I have been updating Christine, who's Eris's wife, and she's actually looped in Eris's parents and brothers on updating about the study, a few other things, and they are so appreciative. It's really touching to see how much this impacts them and how appreciative they are. So I just wanted to pass that along and let people know that Eris is not forgotten, and his family, but more importantly, his family are just so appreciative of all the work that you guys are doing. So let's keep building on screening and eligibility. So next slide. The inclusion criteria are pretty straightforward. So you see the age, it's age 1 year to 21 years inclusive. So up to age 21 years and 364 days. The main question is, how are we defining meningitis? And so if you have an LP, the LP trumps everything. You need to have more than 10 white blood cells per high-powered field. That's uncorrected, so we're not correcting for blood in order to meet the definition of probable meningitis, or excuse me, definite meningitis. If you have less than 10 white blood cells per high-powered field, and actually has happened, we're screening here at Rhode Island, and the RAs picked up a patient. I was really thrilled. They had an LP. And they had 0. It was a champagne tap. They had 0 whites and 0 reds. And so they are out because they had an LP. They did not have meningitis by this definition. But as many of the sites know, that's another thing that's we're finding out that's quite variable. Many of these kids don't get a spinal tap. And so the other way to get in is with the diagnosis of a probable meningitis, which you're defining as you must have a headache and then other signs of meningitis. So neck stiffness or pain, papilledema, or ill appearance. And this only applies if the LP is not done. If the LP is done, then you must use that criteria. Next slide, I think I kind of covered. Yep. So this sort of covers what we were just talking about. If they have an LP, wait and see what the cell count result is. Because if they don't, as in the case I mentioned, they are out. They do not meet inclusion. As I mentioned, you don't need to correct for the presence of blood. And then if a LP either was not done or, as the clinicians know, sometimes an LP is done, but there's not enough CSF and a cell count is not done. So either if an LP is not done or if a cell count was not done, then you shift to, did the patient meet criteria for probable meningitis? So let me stop there and make sure there's see if there's any questions about that. I see Maya put a question in. Yeah, so you must have a headache and an additional symptom. If you can go back a slide. So to meet the definition of probable, you must have a headache. So if you don't have a headache, you don't meet the definition, and have one of the other symptoms of meningitis. Maya, does that answer the question?
Yes, I just wanted to make sure they didn't need to have 2 of those, neck stiffness and papilledema or ill appearance.
No, it's headache and one other symptom. And this is not by no means a comprehensive list, but we tried to pick the ones that were most common. So Christina said, correct, headache alone does not count. Because as, again, the clinicians know, Lyme presents in lots of different ways. And so you could have early disseminated Lyme, have a whole bunch of symptoms, have a headache along with it. But if in your clinical judgment, so there's another question from Tina about what about the duration of headache? I'd like to have Lise chime in, because the way I've been teaching our team, and hopefully I'm not teaching them wrong, is that it's really a question for the clinician. What do you think the diagnosis is? If you think it's early disseminated, they have a headache, but you think it's early disseminated Lyme, and you are not planning on, the clinician is not planning to treat them for Lyme meningitis or CNS Lyme, that's not who we want. However, to Tina's point, if they're coming in and they may or may not have these other things, but they've had a long duration of headache, which I've certainly seen, and the clinician feels like, yeah, no, if the Lyme test comes back positive, I'm going to treat this patient for Lyme meningitis or CNS Lyme, then that is who we're looking for. So please, please chime in. Nope. Lise, we can't hear you. So if you're talking, you're on mute. Nope, I think she's trying to reconnect. Yeah, I'm really curious to hear what Lise has to say. And that's how I've been teaching our team here is does the clinician think, or will they treat them? Let me put it, will they treat them for Lyme meningitis or CNS Lyme if the Lyme test is positive? But if they're saying, well, no, I really think this is early disseminated Lyme, and I'm not going to treat them for Lyme meningitis or CNS Lyme, then that's not who we're looking for. And to Tina's point of certainly seeing kids who chronic headache in a non-headache kind of kid, thought, yeah, this could be Lyme. Okay, and Brenna put in, we can we can get all these questions to Lise. Because for those who don't know, I am not a Lyme expert the way Eris and Lise are. But after Eris's passing, I've been helping Lise out with not only our site, but with the study. Sheila put in a question about they have seen patients with headache, high opening pressure, papilledema, and an LP with less than 10 white blood cells, so they cannot be included. And this one I do know. The answer is yes. By the way this study is designed, if you had an LP and you have less than 10 white blood cells per high-powered field, you do not have definite meningitis. It's a great question, and I'm going to have to defer to Lise and the other Lyme experts on how they came up with this criteria, but I do know that that is a hard stop for this study. If you have an LP and a cell count was obtained, you must have greater than 10 or more white blood cells per high-powered field. I can't tell. Did Lise get back on?
Yes, Tom, I'm back on.
Yeah, your audio is really kind of breaking up, Lise. So why don't we continue, and either when your signal's better, or what we will do is Brenna will collate these questions.
Yeah, I'll continue and I'll answer all questions after the break. Thank you.
Oh, actually, you just got better. So I don't know if you want to try addressing it now, Lise?
Question.
Okay, yeah, sorry. You're kind of spotty again. So yeah, we will defer this till after the break. Okay, so to Sheila and Tina and Christina, we'll hear what Lise has to say. Did you want to add anything to your questions? Okay, if not, let's move forward. Next slide. And I think we covered this slide, so next slide. As Lee's just covered, the other inclusion criteria is that you must have a positive Lyme serology. And that can either be the standard 2-tier test or the modified 2-tier test. One subtlety to this is that you can have both tests, both the first and second tier test, be equivocal, and that counts. So positive does not mean positive. The way to think about positive is you cannot have two negatives. But if you have any combination of equivocals or positive, including both the first and second tier tests are equivocal, that is considered a positive test and they are included. So let me stop there and make sure, let's see if there's any questions on that. Okay, next slide. So the exclusion criteria, couple things. The wording, I think most are familiar with it, but I'll just go through it. The key, they're worded this way because the answer has to be no to all of them. In order to be included in the study, you can't meet any of the exclusions, so the answers to all these questions must be no. So the treatment plan must include either oral doxy or IV ceftriaxone or cefotaxime. Sorry, this is a typo. Because one site said, well, some of our Lyme tests don't come back for 7 days, bullet number 2 should actually be 7 days, that they cannot have had more than 7 days of treatment with antibiotics prior to enrollment, and enrollment is day 1 of the study. So for example, say you're enrolling them on May 10th, Monday, May 10th. That means that the first dose of antibiotics preceding enrollment could not be before Monday, May 3rd. Let's see what else. For bullet number 3, what we're really getting at is the parent or possibly the participant themselves need to be filling out the daily Lyme meningitis symptom survey, and either because they're too ill or cognitively or developmentally impaired, you need to be able to detect whether they have a headache. How are they feeling that day? And so when we're talking about neurocognitive dysfunction, it could be either a chronic condition or an acute condition where the person assessing their Lyme meningitis symptoms says, I can't tell. I can't tell if they had a headache. I can't tell how bad their pain is for whatever reason. That's what we're trying to get at with exclusion number 3. I think number 4 is pretty straightforward. And number 5 is the key is at the time of enrollment. So say in the scenario where an LP is done, the Lyme test is back. So they are known to have Lyme disease. They have greater than 10 white blood cells per high-powered field, but the cell count, or excuse me, the CSF culture is not back. That patient is eligible because at the time of enrollment, they are not known to have bacterial meningitis. Now, if the culture comes back positive and they do have bacterial meningitis, we'll deal with that on the back end. But at the time of enrollment, as long as they are not known to have bacterial meningitis, they are eligible. So let me stop there and see if there's any questions about that. Okay, let's move on. Next slide. I think you guys are all working on this, and I will very quickly go through what we've done here just to hopefully give you some ideas. We are looking at our first line, and for those who were in both the PCARN headache study and this, it actually dovetails somewhat with this study. We're also in Lyme studies. So at our site, we have BPAs for both LPs and a serum Lyme test. which automatically alerts our research team, and they start looking to see if the patient is eligible for that. They are also using their normal screening processes for the Lyme study and for the headache study. So they're mostly looking at chief complaints and orders. We are also reaching out to our teams and asking them to contact our research team when they're there if they think a patient is eligible. After hours, there is a gap overnight where we don't have RE coverage. What we're asking sites to do, or excuse me, our clinicians to do is inform the patient that they might be eligible for the study. Ask them if it's okay for them to contact them if they are, and if they say yes, we give them the pre-enrollment patient information sheet and have the clinician secure chat. In Epic, it's a way of securely linking a patient that's HIPAA compliant and sending a secure chat to our research team. And in the morning, they're now notified of it. They'll follow for the Lyme test results and contact the patient if they are positive. And as I think it was Heather mentioned before, Heather or Brenda mentioned before, that is how we're getting that we're informing the patient of their possible eligibility so that we can contact them later. We've also we're also reaching out to other areas where patients might be identified. By far and away, we think the majority of our patients are going to be identified in the ED. However, we've also reached out to our hospice, our ICU, our neurology clinic, and our ID clinic. I know some of you have a specific Lyme follow-up clinic. They've all, when I've reached out to them, they'd say, no, we don't see these patients. But I still reach out to them and ask them to contact us if they should see a patient like that. We are also looking at, you should be looking at how your site does Lyme testing and how will you follow them, track them, and send the results to the DCC. You can also use your IT folks to help you potentially set up a screen for that. Next slide. So again, these are just some other, I think we've sort of covered this. These are basic terms that you might want to use to screen in your EHR, either if you can do it electronically or with your research team. Next slide. And then let's turn to some scenarios. So if you can, next slide, get your phone out because we'll be asking you to complete a survey. Just scan the QR code on your screen. So in our first scenario, we have a 10-year-old female who is referred by their PCP with 10 days of headache that is worse with their head or their neck, and also some diffuse myalgias. There was no fever, but there was, and there's no fever, there's no meningismus, there was no rash and no other ill symptoms. The PCP ordered a modified 2-tier test 3 days ago through an outside lab. The results were an equivocal first-tier EIA and a positive second-tier EIA, and they're sending them to the ED for a second opinion. So in the ED, she's non-toxic, she's afebrile, her vital signs are stable, her physical exam is exactly as the PCP described. You clinically do think she has Lyme meningitis, and you plan to discharge with oral doxycycline. So in your survey, please let us know whether you think the patient is eligible or not. We'll give that a few minutes, and Bruno will post the results in the chat. Bruno, do we have enough? Should we give a little more time? Oh, okay, there you go. So next slide. And great, everyone got it. Yes, it got it correct. Oh, sorry, next slide if we can. And that is the correct answer. This patient is eligible. Whoops, can we go back one? Yep. The main issue here, and this actually, and Lise will tell you more about the first, this actually was our study's first patient. It was an outside test. They were referred to the ED. And the main points from this scenario are you need to somehow confirm the results of the outside test. And really, it can be anything. It can be, they have a picture of it on their phone. Ideally, it'd be a fax or sometimes an Epic. I know through Care Everywhere, I can access outside labs, but you need some kind of confirmation, not just verbal. Oh yeah, the test was positive. And the second was that the other point is that you do not, it's not required that it's your lab. It can be any lab as long as you can verify that it is a valid 2-tier test. I see Lise is back.
Yeah, I'm back. Yeah, I agree with Tom. I don't have much to add. You know, I think that because of the craziness of Lyme testing, non-standard approaches, interpretation, we really need to confirm the presence or absence of Lyme disease, and we need written documentation of that. So however you get it, it's something to save away in the patient's file if it's not done in your hospital system. And this has come up a couple times, so I think it may also be a scenario that you face at your sites where the the pediatrician, the clinician is testing before they even come to you. So thank you.
Okay. If there are no questions, I'll give that a few seconds. Let's move on to the second scenario. Scenario number 2, an 8-year-old male was seen 2 days ago with fever and severe headache and was very ill appearing. He did get a spinal tap as part of his initial workup and also got Lyme serologies. The CSF showed 550 white blood cells with a neutrophil predominance, a negative gram stain for organisms, normal glucose, and mildly elevated protein. The team was concerned about them, so they admitted him, treated him with IV ceftriaxone and vancomycin. After 2 days, his CSF culture was negative. His first tier Lyme EIA was equivocal, and his second tier EIA was positive. The treating clinicians plan to treat him for Lyme meningitis with IV ceftriaxone through a PICC line. Is this patient eligible?
Is that supposed to say IV ceftriaxone? It says cefotaxime.
Nope, that we put that in there for a reason, and
Okay.
they do want to go with IV cefotaxime through the PICC line.
But you do raise the question that because ceftriaxone lasts 24 hours, most of the time it is ceftriaxone that's chosen.
So Brenna, we're ready to move to the next slide? Okay, great. Okay, so I'm really curious to hear, I think we can guess, the folks who voted no. The answer is the patient is eligible. He meets all the inclusion and does not meet any exclusion criteria. And I'm guessing what tripped people up is the cefotaxime. And for this study, ceftriaxone by far and away is going to be the IV medication that you see more often, but cefotaxime does count. So if someone has a preference for that, they are still included in the study. Do folks want to comment on that? Either Lise or did they get tripped up on something else, or was that? From an antimicrobial perspective, I think all the clinicians know they're basically the same. Ceftriaxone has the advantage of being dosed. It can be dosed once a day, where cefotaxime must be at least twice a day. So it's going to be less common. but we wanted to be inclusive and we didn't want to exclude anyone. If someone has a preference for cefotaxime, we didn't want to exclude them. Okay, if there's no other questions or comments, let's move to the next scenario. So now we have a 16-year-old male who's presented to the neurology clinic for a persistent headache. 10 days ago, his PCP sent a Lyme serology for his headache and mild neck pain. 2 days later, the first tier Lyme EIA and the second tier immunoblot were positive. And 8 days ago, the PCP, or excuse me, the neurologist started, sorry, got that wrong. The PCP started him on oral doxycycline. The headache is not improving, so the PCP referred the patient to the neurology clinic for further evaluation of his chronic headache. Is this patient eligible? Oh, and I've been saying Brenna, it's Audrey. So Audrey, are we ready to? Okay. All right, everyone got it correct. Next slide. Correct. This patient is not eligible, and they're meeting 2 exclusion criteria. Their Lyme test was positive more than 7 days ago, and they've been on antibiotics for more than 8 days. Excuse me, more than 7 days. So yeah, this patient actually meets 2 exclusion criteria. I think that's pretty straightforward. Any questions or comments? If not, let's go to the, I think this is, that was the, yep, I think that was the last one. Okay, I will turn things over. Oh, well, sorry, that's me. So Tina put in a question in the chat, and her question was, what if only the IgG is positive? Are they still eligible? And clarified, for a patient like that with chronic headache, it's likely a red herring. Tina, do you want to make a comment? Yeah, or Liz or Tina?
Sure, I'll jump in, and Tina, you're the infectious disease specialist, so I'll defer to you. But I think there's 2 issues for people that are using standard 2-tier testing. So first of all, the IgM can be falsely positive, particularly in longer duration. That's why it has to be less than 30 days of symptoms for the IgM. The issue with the IgG is once you've had previous Lyme disease, you can persistently have a positive IgG, even if the acute infection is not Lyme disease. However, the background seroprevalence of positive IgG in our children, and this is actually a study that RS led a few years ago, is only 1% or even less than 1%. So if you have a patient with a headache, and signs of meningitis, or a positive LP and a positive IgG for Lyme disease, I would consider that active Lyme disease, since the background seroprevalence is very low, and you have acute signs and symptoms. So in our case, regardless of the duration of symptoms, with a positive IgG, they would be eligible as long as their treatment duration and testing duration fit within our criteria. Does that answer your question, Tina? Please feel free to jump in. Thank you. Great.
Okay, I think this is my last slide. Next slide.
This is actually me, Tom, for a minute.
Oh, sorry, duh.
And then it comes back to you.
Okay, got it.
Okay, so the next phase of the workflow is the participant parent training. This will happen at the same time as the consent process. Okay, so the research staff should walk the family through daily expectations until symptoms resolve. If the participant has facial palsy, please show them how to take and upload photos. During the facial palsy photo training, it is preferred that the research staff either offers to capture the baseline photos of the participant or guide them through the process of taking and uploading the baseline photos in real time. This ensures there is one complete set of photos. Be sure to give the them time to ask questions. Next slide, please. I'm going to quickly walk you through the instructions for taking photos. The first photo should be neutral expression at rest, think passport photo. The second, they should smile. Third, close eyes tight. Fourth, wrinkle forehead by lifting eyebrows. And last, pretend to blow up a balloon with puffed cheeks. Please also ask parents to put the child in front of a neutral background and make sure there are no other people in the photo. We'll be going over how to upload the photos in the red cap portion of the training. I'm just reading this last comment. Will the central study staff be doing this training with the family? We don't have staff to do this at my site. This is the responsibility at each site to train them on these things.
Okay, that was my comment. This is Maya Rutman from Dartmouth. We have pretty limited staff. It's pretty much me and a resident and a medical student. So we were under the impression that the training on this particular app and its use would be taking place centrally. Has that been a change?
No, this is always planned on. The site would train the families. However, we do have an information sheet that goes through exactly how to do this. So if someone is not available to train them, you can hand them the information sheet and hope that they can figure it out. But and I don't know, maybe we can address this question at the DCC, and if this situation came up, maybe we could do a quick training session for anyone at your site that needed it.
Yeah, and Maya, we anticipate, just based on prior literature, that about 25% of children with Lyme meningitis will have facial palsy, and each site is enrolling, 5 to 10 patients a year. And so this is going to happen twice a year. And it really is just taking them through the sheet, which then, if it's an in-person consent, can be handed to them. And if it's an electronic consent, can be shared via text or email with them to review. And it's not an app, it's just a red cap form. It's pretty straightforward. I'm sure all your team will pick it up quickly, but it's just making sure that the family understands. But it's going to be a very infrequent event for all the sites.
I was going to add, Maya, that I think definitely between the DCC and Lise and myself, let's talk about this offline, and we can figure out how to make it work at your site.
Great. Next slide, please.
Yeah, Maya can train your people at your site.
Okay. The next step will be explain how they will be reimbursed for their participation. Participants will receive a CLIN card, which is a type of debit card that Boston Children's Hospital can load money onto as the study activities are completed. Inform the participants that their CLIN card will arrive through mail directly from Boston Children's Hospital. This is why it is necessary to collect a home address. There's also a CLIN card FAQ in the with basic instructions as part of the enrollment packet. Next slide. So now I'm going to talk about the enrollment packet. I've referred to it a couple times. Okay, the enrollment packet has two parts: the RC resources, which should be printed before approaching a participant, and the packet for participants, which should be printed and handed to participants if they are in the hospital, or emailed if they have gone home. The RC packet includes the workflow checklist, which you should pull from your local site folder in eBinder, the eligibility worksheet, which is also located in eBinder, the documentation of informed consent checklist, which also acts as a call log if consent and assent will be obtained over the phone. The packet for participants includes the pre-enrollment information sheet. So this also will need to be pulled from your local IRB folder, since each sheet is site specific. The facial droop information form. This will only be for participants with facial droop. It includes a summary of facial droop, how long they will need to take photos, and how to take and upload photos. The CLIN card information sheet. This is a detailed FAQ about the CLIN card. And lastly, the outline of study activities for participants. This form details what will happen daily, weekly, at 6 weeks, and at 6 months. This is a resource for participants and parents. If time allows, please walk them through this form and make sure to ask if they have any questions. Next slide. So this is just a screenshot of eBinder, and all of the documents that we just covered, with the exception of the pre-enrollment information sheet and workflow, can be found in the trial master file in eBinder. Within the folder, there is the table of contents, which lists each of the documents, and then a separate folder for the RC documents and participant documents. Next slide. You also want to make sure to explain the 6-week qualitative interview. A research staff from Rhode Island Hospital may be contacting them at approximately 6 weeks from their ED visit to talk to them about how they are feeling and how the illness affected them. Is Sarah Vargas on the call right now? If she was on, she was going to present these slides. If not, I will. Okay, looks like she had to step away for a minute. This is just a brief summary so that you know the purpose of the 6-week interview. You will not need to do anything with this interview process other than inform the participants about the follow-up call. The interview will be conducted 6 weeks post-study enrollment. It will be a telephone interview with trained experts. The COI has more than 10 years interviewing and supervising experience on a variety of health topics, including Lyme disease and pediatric asthma. The slide details who will participate in the survey based on the age of the participant. The interview will consist of open-ended questions exploring treatment preferences. They are anchored by baseline treatment options and preference questions. Next slide. Oops, all of that was on this slide. So the only thing I didn't go over is the participants. It shows the ages of those. So if they are less than 8 years old, the caregiver will answer the survey. If they are between 8 and 17, it will be the participant or the caregiver, and then the participant if they want to participate. And greater than 17 will be the participant, and then if they want their caregiver to also do the survey. Next slide. The objectives of the interview are to ask patients to describe in their own words their initial impressions and/or preferences for Lyme meningitis treatment, their interactions with providers around antibiotic treatment options and decision-making, their initial satisfaction with treatment plan, subsequent experiences with treatment and outcomes, and their current satisfaction and preferences. Next slide. Follow-up for this study will not be the responsibility of the site RC. Rhode Island Hospital or possibly Boston Children's Hospital will be conducting all follow-up. If daily, weekly forms are not filled out or if photos have not been uploaded, a research staff member will be checking on them. Next slide. Now Tom will go into a little bit more detail on that.
So thanks. Next slide. So it's a pretty straightforward. I think you guys are all used to the screening, the consent. There are some baseline assessments that need to be done on the day that you consent. There is a 6-month medical record review, which is again EHR only, so that should be fairly straightforward. And then the usual resolution of queries, which the DCC will send out as needed, and then just communicating with the 2 teams. The main thing that we're, one thing that we, the centralized follow-up site might ask you is if sorry, let me backtrack a second. Participants will be receiving automated REDCap surveys. Here at Rhode Island Hospital, our team will be checking to see whether they're being completed. The DCC is going to provide us a dashboard of that, so we can see when surveys are not being done. Our team will then reach out to them, the participants, if they haven't completed their surveys. We're thinking that for the majority of surveys, that's all that's going to be needed. However, if that fails, if both the automated REDCap reminders and our attempts to contact them, phone, email, text, are not successful, we may reach out to the sites to ask them to help follow up and contact the participant. At that point, they are probably lost to follow up if they're not responding to that. But just one more attempt to include them in the study. So we anticipate that will be pretty infrequent, but that is something that we might ask sites to do. That was really. So what we're doing is we're coordinating that follow up, and Boston is coordinating the clin cards. So those are things that you will not need to do. Any questions about that? Otherwise,
yeah, just to augment, I mean, again, if we're losing them to follow up, particularly in that first phases before their symptoms have resolved, but you know that they're coming back to the hospital and could meet with them or to talk to a provider to remind them, we may utilize that. But of course, we hope that the automated methods work. And then if not, the phone call from RIH. And that's all included in the data sharing and the informed consent. That's why we set it up that way, so that we could centralize the follow-up. Are there questions about that? These are, uncommon patients. And so once we get, find the patients and get them to consent, we're going to want to do everything possible to get the data that we're looking for. There's not, it's an infrequent number. So we really want to make sure we get all the information we need, minimizing the loss to follow-up. So thank you in advance for all your help with that.
Thank you. If there's no other questions, let's go on a 10-minute break and reconvene at 11:45 Mountain and 1:45 Eastern.
Thanks, team, for covering for me. Are you there, Tom or Brenna or Ulrike?
Yeah, I'm still here.
Okay, good. No, I'm so sorry. It's on my calendar at 1. And so I'm in a good Wi-Fi signal now, and I just wasn't at noon and then had to drive. So I'm so sorry. Just wrong scheduling. So I'm here now.
Okay.
Maybe we should take a minute before we get in and just have Lise go through those questions that we got in the first half.
Yeah, I'm copying them to Lee because I'm assuming you have to break off. So I'm copying all the questions so you can see it, and I'm directly messaging Lee with them.
Yeah, no, it's perfect. And I think, Tom, you did a great job, but we'll make sure that there aren't any other questions. And, I could kind of hear things, but couldn't really participate. So my apologies. It just planned my day wrong. So thank you.
No, I actually thought it went okay. So.
Yeah, no, you guys did great. And so thank you. Thanks for covering.
Yeah, there have been lots of great questions in this session, and most from PIs, so that's been great.
Yeah.
Good. Perfect. All right, everyone should take their break too, and I'm here, so I'm ready.
Okay.
Awesome.
All right, bye.
All right, it's 11:45. I think we can go ahead and continue. I think Lisa, it would be helpful to go through and address a couple of the outstanding questions that were posted in the chat. One of them was regarding your first enrolled patient, how they were identified, essentially, how did you communicate at your site, and what that process was like. If you could provide a little bit of feedback, I think that would be very helpful.
Sure, thanks, and welcome back, everyone. So the questions that I saw, I think Tom and the team did a great job answering, but there was the question about headache alone and whether that's enough to meet the probable meningitis definition. We're really looking for patients who, have other signs and symptoms of meningitis as well. Tom, I think you addressed that really well, but just that was one of the questions in the chat. And then the second or I believe somebody asked about the first enrollment, and I started to share and had bad signal. So I think we had a really nice first enrollment because sorry, we were trying to we were able to do it in person, and the situation was that the patient had Lyme meningitis diagnosed by their primary care physician, so the testing had been done by their primary care physician, and they had come to the emergency room for questions around severity of symptoms and complications from the treatment. They were on oral doxycycline. So the tricky part came up for finding the outside results and getting a written documentation, but they were in front of us when they had met eligibility criteria. They only had been treated for a few days. And so that went smoothly, but we did have to sort of figure out how we could share those results, which were not accessible on our information system. The patient and the parent were super excited about participating, so we were lucky in that way. They were very eager participants, but the main glitch that we had was the documentation of the outside results. Were there specific questions that I haven't addressed?
Lisa, I don't know if you had anything to add or if you were muting because it was background noise.
Great, that should be it.
Okay. Are there any other questions for Lisa at this point? Okay, then I think we can go ahead and move on to the next slide. So I'll just be covering the baseline data collection forms for the next 10-15 minutes. Next slide, please. So our baseline activities are broken down by case report forms, and those are the ones that need to be, there's some that need to be collected and entered on the same day. Then there's also some baseline forms that need to be collected at baseline, but do not need to be entered on the same day. There are a few forms that require a chart review, and then there's one form that requires feedback from the treating clinician. And as Brenna mentioned, all of these forms can be found in eBinder as PDF worksheets as well. Next slide, please. So let's just start with the CRFs that need to be collected and entered into REDCap the same day as you obtained consent. And here, just to emphasize, same day data entry into REDCap is key as the information drive the daily and also weekly surveys. So the CRFs that you see listed here, we'll go ahead and walk through them on the next few slides. Please go ahead. So for demographics, so the goal of this form is to collect all relevant contact information for the participant in order to send out the REDCap surveys and also to allow for us to compensate the participants via CLIN cards. I have listed the data elements that need to be completed on the forms here on the slide. The key information on this form really are the cell phone number and the participant's home address. Cell phone number is needed to send the surveys via text messages, SMS, and the address is also key information as we will use that to mail the CLIN cards to the participant. So please make sure you enter all the relevant information into REDCap. We've also created an open text field to collect alternate contact information. So for example, a spouse, a second parent, additional phone numbers, and so forth. So if you, for example, have a participant that lives at more than one address, please enter the zip code of the primary residence, so where the participant spends most of the time. Next slide, please. Information should be obtained by the RC in the presence of the participant, so either at the bedside in the hospital or via a phone call if the participant has already been discharged. The participant should indicate their preferred method for receiving these survey links and also survey reminders. We do, however, ask the RCs by default to please use the text message option as the preferred method, unless they explicitly say they do not want to receive text messages. So if that's the case, then please select email as a backup. Next slide, please. For the demographics form, you can see all the data elements here listed on the slide. The key data element here really is the participant's age, as age determines the appropriate PedsQL survey link that will be sent out. And as already mentioned, participants must be between 1 year and 21 years of age at the time they're approached to be included in the study. If they're less than 1 year or older than 22 years, they are ineligible. Other data elements include participants' gender, ethnicity, and race, for which you can select all that apply. And we do also ask the preferred survey language, which is currently English only, the annual household income, and also the highest education level. Next slide. So this next form is the pediatric Lyme meningitis symptom form. This form aims to assess the current Lyme meningitis symptoms, which includes symptoms like headache, neck pain, fever, sensitivity to light, or any other problems with their vision. Please do remind the participant that this form will be sent to them via text message or email, kind of depending on the preferred method. And it needs to be completed daily until resolution of symptoms or 30 days. So whichever occurs first. So please just remind the participants of that. And then also, this is a good point to remind them that the completion of these surveys are tied into the compensation via claim cards. If the participants have been discharged and the surveys cannot be collected over the phone, there is a way that you can send them manually through REDCap, and we do have instructions on how to do that in the MOOC, but Bethany will also cover that in the REDCap chapter here in a little bit. Next slide. The history of present illness form will be abstracted from the EHR and reviewed and discussed with the participants. We do want to know information regarding possible previous tick bites, headaches, and other present clinical symptoms. So if a previous Lyme disease was diagnosed, we want to know the year that occurred. Does the participant have a history of a recognized tick bite within the last 6 months? And also, does the participant have any headaches due to current Lyme meningitis illness? Next slide. The form also asks about neck pain, fever, facial droop due to Lyme meningitis. And here for this slide, I really just want to highlight the facial droop question, as this is tied into the actual facial droop REDCap form. So if the answer to this question is yes, it triggers additional questions and there's additional data entry required on the particular facial droop form. And if the answer is no, then the form just needs to be completed and there's no additional questions that will auto-populate. You might also see children who are too young to communicate their symptoms. If that's the case, then please ask the parents to make their best assessment of whether a young child has a headache, a light sensitivity, and double vision. Parents can, for example, watch for excessive crying, touching their heads, or tightly closing their eyes to avoid painful stimuli. Next slide, please. The basal facial droop measurement form, really the aim of this form is to capture the facial palsy pictures, which we've already talked about, of the participants if they're currently experiencing facial droop. As mentioned, this form should be completed by the RC either at the bedside or via phone call if the participant has gone home. And we do have that instruction sheet that is available in eBinder as your reference. Next slide. And then these following REDCap forms also require direct participant interaction and should be obtained the same day as consent. However, the data entry for these forms is not required to occur on the same day. So let's just walk through these two forms. It's the PedsQL form on the next slide, please. So you can see there are multiple PedsQL forms available in REDCap. They start with the infant age of 13 to 23 months, all the way to the teen version for ages 13 to 17 years. And then starting at age 18, they are self-reported and not parent-reported anymore. So for the baseline form, which is really the only time that you will need to worry about this form, you will need to manually select the age-appropriate PedsQL form to go through with the participant. All subsequent PedsQL surveys will be sent out automatically. And that again is based on the date of birth that was entered on the demographics form. Next slide. And then just a couple things to note for the PedsQL forms. You might run into a situation when there's no time to obtain the information from the participant. In that case, you can also send this form manually through REDCap and still obtain the information from them. And as mentioned, Bethany will talk about that in a minute. And then also please note that if a participant moves between age groups over the study period, the same PedsQL forms will be used. This next form is the treatment preference form, which is assessed by directly asking the participant or by giving the participant a device like a smartphone, tablet to complete the forms themselves. Preface these questions by asking them to think of any conversation they've had with their provider about treatment options or preferences for their child's Lyme meningitis treatment. And then similar to the PedsQL form that we just talked about, there is a way to manually send the surveys to REDCap. Next form. Moving on to the EHR chart review, these forms should be completed based on a chart review by the RC. And I'm not going to talk about the lab results form here as we covered that earlier on. And we will also again review it in our REDCap training. The data elements for the ECG form are also very straightforward and will be part of the REDCap training. I just really want to mention the medical history form, where I just want to point out that we're only looking at the participants' past year's medical history. So we're especially interested in allergies to antibiotics, for which we have some examples here listed on the slide, and they are also listed in the MOO as well. And then for the medication history form, we're interested in antibiotics and corticosteroids taken in the last 7 days. And again, we do have specifics and examples listed in the MOO that you can reference, but do know that these forms are repeating forms, so you can always add multiple medications on this form as well. Next slide. And then this last baseline CRF is the clinical assessment form, which includes questions regarding the physical exam and the clinician treatment preference. REDCap forms can be completed by the treating clinician within 24 hours of consent. And then this information should be entered into REDCap as soon as possible after completion. And we'll have some visual screenshots of this form when Bethany covers the REDCap training as well. So just in summary, these are the forms that, there are forms that are participant facing and some that are not. And I just wanted to reiterate the importance of doing some of the data entry that is driving some of the surveys, the weekly surveys. So just keeping that in mind. And as we move on, let's go to the next slide. And then there's just one more slide on follow-up. So this last step, next slide. This last step is a medical record review, which happens at approximately 6 months after enrollment. And as Tom already mentioned, completion of the CRF falls onto the site RC. who will need to complete this medical record review at approximately 6 months. We're currently finalizing the form on our end, and we'll provide additional information in one of our upcoming all-site calls. Are there any questions before we move on to the database training?
Sorry, quick, this is Christina. So how many surveys will be sent to the patients' families? Once a week? Is that what you said? For 6 weeks?
Yeah, and Bethany will go into that in a minute as well. Yeah.
Are we ready?
Any other questions? I don't see any in the chat, so I think Tessa, you can go ahead.
Perfect. Okay, my name is Tessa Stappert, and I'm a clinical data manager at the DCC. I'm going to give a brief overview of a program we are going to use to help monitor data for this study called Query Manager. In addition to this presentation, we will also ask you to complete a short Moodle training video and quiz before you gain access to the system. You will access Query Manager through a website URL, which will be available to you after you complete that training. This is a website you will want to check every day if possible, so it's a good idea to bookmark it. Next slide. Next slide. There we go. When you first access the Query Manager website, you will be brought to the login screen. If your site participates in other studies managed by the DCC, you might have other studies you use this for. You're going to select Lyme Meningitis from the Select Study drop-down menu and enter your username and password. Query Manager is connected with the REDCap database itself, so the username and password is going to be the same one that you will use for the database. The lead CDM, Bethany, will be showing you the database after we go over Query Manager. Next slide. After signing in, you will be brought to the home screen. The home screen will give you some basic information about the queries available for you to handle. A query is a data discrepancy that has been flagged for someone to review. This could be missing data, inconsistent data, like dates that don't match up or are in the future, or something else. At the DCC, we program rules within Query Manager that look for specific discrepancies that could be problematic in the study. Depending on what the discrepancy is, some of these go straight to you to review, you being the RCs, and some go straight to the DCC. This gray section up top is the summary of unresolved queries. You can see that some of the queries are sorted for different people to go through. This is the section you'll probably use the most. If you are looking for a specific query, you can also use the search filters below to find what you are looking for. Next screen. This is just a little closer of that section on the home screen you will see every time you log in. The number under site review is what you will probably want to click on first. These are the queries that have been assigned to your study site. So that means all of these have to do with participants enrolled at your site and data that was entered into the database for them. The numbers in the middle section are queries that have been sent to different parts of the DCC for review. And the number on the far right is the total number of unresolved queries for your site, not divided by who needs to review them. Next slide. So all of these numbers are clickable. When you click on the number underneath site review, it will take you to a list of queries for you to review in a search results screen. Next slide. Here is the list of queries available to review. You can add some additional columns to the table if you find they are helpful. You probably will not need to add others, but it's an option. This slideshow will also be available for you to view later for reference. So if you have questions about these slides, those will be available for you to review. Next slide. On this table, there is the query ID, which is a unique number. There is a subject ID that's going to match up with the participant's number in the database. The name of the form that the discrepancy is on, the status of the query, how long ago the discrepancy was flagged, and the date that it was flagged. Each of these blue query ID numbers on the list are clickable. To look into a query, click on the number. Next slide. This will take you to the query details screen. There is a lot of information attached to each query, so you will want to look closely to figure out what needs to be done to resolve the query. Look closely at the subject ID number, the study event, and the form name. That will help you locate where in the database you need to double check. The section and header details can help you narrow things down as well on some of those really long forms that have lots of sections. Next slide. The query term section describes exactly what was flagged and why. You will read it to decide how to approach the query. For this example, the query term tells you that one of the inclusion criteria was marked no, but all inclusion criteria need to be answered yes. To resolve this query, what you need to do is check the source documentation to see if the answer is actually supposed to be no, or if there was a data entry error. As it says on the right, there could be two options. One, if the answer is supposed to be yes, and this was a data entry error, if you go back into the database, go to this form and change that answer to yes. After you do that, you can go back to this query and click next up above and ignore the rest of the form because you resolved the query. Or two, if the data is correct, then you would need to add a message to us at the DCC to say that. You could say, checked source document and inclusion is marked no, or whatever it is that explains why the data is the way that it is. Then click request DCC review. This will bump your message back to us so we can read it over and manually resolve the query. Next slide. To recap, when you modify data in the database to correct a data entry error, Query Manager will recognize that you fixed what was flagged, and it will go ahead and automatically resolve that query for you overnight. You won't need to add any notes or anything, just fix it in the database, and it won't disappear right away, the query, because the data is checked every 24 hours in the middle of the night, but it will be gone from your dashboard the following day. If the discrepancy is true, but Query Manager flagged it anyway, and you provided an explanation to us and clicked request DCC review, that will send it back to us so we can resolve it. Every once in a while, there's a little back and forth messaging, but we try to keep it brief because this all goes into the final database as an audit trail. So we know what is going on with all the data, why things were changed, why they are the way that they are. Eventually, all of the queries do get resolved. Next slide. This is an example of an email notification that you will get on days that you have active queries to resolve. This will go to the email you have on your DCC account, which you will set up later if you don't already work on studies that we manage. Next slide. These are just some helpful tips about Query Manager. Although it says that Firefox is the recommended browser, you can access it through Chrome or your preferred browser. It usually works okay. You do want to try to use the navigation buttons that are within Query Manager rather than using the back button and forward button and those things that are in your browser. That will be a little bit clearer once you get into the system and use it. And it's also a little bit clearer on the Moodle training video that will show you how to use Query Manager a little bit more. If you have any questions, you can contact either Bethany or me and we will assist you. That is all I have today. And I'm going to hand it over to Bethany to talk about REDCap.
Hi there. I'm just going to share my, oh, does everyone see my screen? Let me.
We see your desktop right now.
Right, okay, let me get the presentation going. It didn't do it the way I wanted it to, which it never does. Can I share a different screen? Let's see. Sorry, guys. Let me just, there, sure. It doesn't let me choose the screen that I want to share. There we go. Yay, I figured it out. Okay, so let me go back. Okay, so I'm Bethany Fuller. I'm the lead clinical data manager for this study. And I will be showing you a little bit about REDCap. There is a training for this as well that will go into more details for those of you that aren't as familiar, but I believe most of you are familiar with the REDCap program. And then we're going to spend most of our time in this training just discussing the specific forms, looking at them, and kind of Brenna and Ulrika did a great job explaining what kind of data we're capturing and the ins and outs of the time points. And so hopefully this will just put an image to help you make all the connections. So in REDCap, in the left margin under data collection, you can click on record status dashboard, and you can see a quick summary of all the subjects at your study site with their color-coded status by reviewing the dashboard. From here, you can go to a specific subject or form by clicking on a record ID or the associated radio button for the form. Occasionally, you may need to request that a subject record be removed. If a subject is added in REDCap in error, it needs to be removed. Then email the clinical data manager with the request. That's myself or Tessa. And the request must be in writing for documentation purposes, include the record ID and the reason for the removal. And then once an ID is removed, any queries that are associated with the ID that our inquiry manager will also be resolved. Okay, so this is the eligibility form. It starts by confirming the inclusion criteria is met. So only if the inclusion criteria is met are we going to want to enter the person into the REDCap EDC. Otherwise, they should not be entered. If all the inclusion criteria is met, then respond to all of the questions for the exclusion criteria. If the subject is eligible, continue with data entry. The form will open new questions regarding the consent process and date of consent. If the subject is not eligible, data entry is complete. So there are several forms that will be collected as part of the baseline event, as was discussed by Ulrika and Brenna. And it is important to collect this data and enter it into the system in a timely manner, as we previously discussed. We will now review the forms in detail. And this, honestly, this baseline event, like I have here, this is your heavy lifting. This is like 95% of what you're going to be doing as an RC is this main data point here. The baseline event should start with a contact information form. It's important to collect the cell phone only if there is no cell phone number or an email is absolutely the preferred method by the participant should the surveys be sent via email. If the participant is a minor, then a field will appear to collect a name for the parent or caregiver. This field is required and must be collected. Collecting an alternative phone number is also optional and encouraged to ensure effective follow-up. This number is not specific to texting and does not need to be a cell phone number. Entering an email address is optional, but be sure that if there is no cell phone number or if the participant wants to receive the survey via email, that this field is completed. Also, if the participant is a minor, make sure that the email is for the parent or caretaker of the minor participant and not that of the minor. That also goes for the cell phone number. Make sure that the data you're collecting for minors is always for the caregiver or parent. On this form, you will collect the mailing address for sending the CLIN card. Alternative information collection is optional, but highly recommended in case over the course of the 6-month trial, there is difficulty getting in touch with the participant or the family. This is open text, and you can enter any and all information such as names of people to contact, their phone number, address, email address, the relationship that they have to the participant, and anything that's helpful for you to identify and get in touch with the participant and their family. Lastly, if it's preferred that the surveys are received via text message, but there is the option of the email invitation, if that option is not available or preferred by the participant or the parent guardian. So the RC should encourage text whenever possible. I know I've said this a million times, but select text or email to designate the way the surveys are sent. So this field is very important because which one you select, the text message or the email invitation, is the way that they will receive it. Okay, and this is also important to have it completed on the same day as enrollment, because that first survey goes out day one, which is the very next day. So this needs to get done at the same day as the enrollment. In the demographics form, it's important to collect the date of birth, which will verify that the subject is between 1 to 21 years old. That date will also trigger the correct PEDS-QL surveys to be sent at the 6-week and the 6-month event. So this is a very important field to have entered. Here's a look at more fields on the demographics form. So we'll be collecting ethnicity, race, the preferred language, which right now you only have the English option, but once the Spanish is set up, you will have both options to choose from. And then this is the rest of the form. So we'll also be collecting the education of the primary caregiver as the highest education. If there's multiple caregivers, you just choose the highest between all of them. The number of people in the household and the income range. So this is the medical history form. It only needs to include conditions that have been active in the past year that are considered relative to the study. So this is a pretty basic, straightforward form. The lab results. So in the lab results form, we're going to be collecting all of the results, including the Lyme disease test results. So please be sure to complete all of these fields with accuracy. The Lyme disease test will be asking for 2 dates initially. It has the date the serology test was ordered and the date that the 2-tier Lyme test results were available. The lab results try to capture the varying results of the labs across all of the sites. So please choose the options that correspond with your local lab results. The first tier EIA results can be qualitative or quantitative. If qualitative, you'll need to mark the results for IgG, IgM, or overall. And the results of these tests should produce positive, equivocal, or negative results. If any of these were not part of the lab assessments, then mark the test not assessed. If quantitative, you'll need to enter the index value. This will be a numeric value with up to 2 decimal places. As local labs may vary, also record the number if this number was analyzed by your site, meaning your local lab, as positive, equivocal, or negative, because that result may also vary between sites. And the lab questions for the 2nd-tier Lyme test are determined by the selection that are made on the eligibility form for the Lyme disease test. So when you're filling out the eligibility, this question in particular that you see here is important to mark correctly. So there's 2 yes possible answers, and one will say that it was yes via a standard 2-tiered serology or yes via a modified 2-tiered serology. And then which one you choose, it prompts the questions that will come through your lab results test. So it's very important that you mark this correctly. So for the standard test, this uses an immunoblot test. Mark the test results as positive or negative for IgG or IgM results, and then upload the test to be examined by the central PI for the KDA bands. And if the IgG or IgM results were not done, then mark it as not assessed. The modified test uses another EIA test. Currently, this test will always be quantitative. This will produce an IgG and IgM numeric result with up to 2 decimal places. Please indicate the local lab's evaluation of the results being positive, equivocal, or negative, just as in the other test. So also in the lab results, there are up to 6 peripheral blood tests that the study will be collecting information on. We need you to provide the results for all the tests that were collected for each participant, or mark none if none of them were collected. And then for each of the tests that you select that were collected, you'll need to enter the date of the collection for each of them, and these will populate according to the ones that you choose. Also enter the date of the collection for the CBC test. The results should be an integer whole number. Indicate whether or not differentials were collected, and if they were collected, provide the differential results. Enter the date of the collection for blood culture and indicate whether the culture was positive or negative for bacteria. You'll need to enter the date of the collection for the lumbar puncture, select all the test results received from the lumbar puncture, or select none if none of the tests displayed were assessed on the lumbar puncture. The ECG results will not be available for every participant, but if they were collected as part of their care, then we do want those results included. So if the ECG was not collected, simply mark this form no, and the form is complete. If the participant has ECG results, then mark yes and complete the sequential questions. If the ECG results are normal, simply indicate this in the form responses and then mark the form complete. However, abnormal ECG results should be uploaded for review by the central study team. Once the file upload is complete, answer the next sequence of questions regarding previous ECG results. If there was no previous ECG performed, then mark no, and the form is complete. If a previous ECG was performed and showed the same abnormal results, upload the previous ECG results for further review and mark the form complete. Otherwise, indicate that the abnormal results were not present on the previous ECG and mark the form complete. Okay, so for medication history, it is important for establishing any medications taken within 7 days of enrollment, especially those pertaining to the study, such as antibiotics and steroids. Try to answer as much information as possible on this form from information found in the participant's electronic medical record, and then later verify if the information is correct. Select all antibiotics that have been prescribed within the last 7 days. If the participant has started taking the prescription, record the dose and frequency, start date and stop date, or if the participant is still taking the medication. If the participant has not started taking the prescription, simply record the dose and frequency. The rest will be collected in the daily surveys. The same method of data collection is true for the IV as well as the oral prescriptions. If the participant has started taking the prescription, record the dose and frequency, start date and stop date, or if the participant is still taking the medication. If the participant has not started taking the prescription, simply record the dose and the frequency. And if the participant was prescribed any other antibiotics within 7 days of enrollment, please start by selecting the total number of other prescriptions that were prescribed during the 7 days time frame. This is specific to prescription antibiotics in this section. The EDC will allow up to 5 entries of other antibiotics. For other antibiotics, the study is only interested in collecting the name of the antibiotic when they started and stopped, or if they are still being taken by the participant. Dose and frequency is not needed for these other antibiotics that are not being observed in the study. And here is a visual of how the fields will look. Oh, no, I took that part out. Sorry. They'll just line up in rows, one after another, if there were multiple to enter. The medication history form will also ask about the names of corticosteroids prescribed in the 7 days leading up to the enrollment. This is a two-part question about what has been prescribed and whether it's been taken by the participant. The study is only interested in collecting the name, start date, and stop date, or if the participant is still taking the steroid. At the end of the entry, you'll be asked if any other steroids were prescribed in the 7-day time frame. And if yes, then another field will populate for you to record additional corticosteroid information. Or by marking no, this section is now complete. The EDC will allow up to 3 corticosteroids to be entered for this 7-day time frame. And lastly, the medication history form will collect the names of any other prescription medications that the participant takes regularly. The study will only be collecting the names of these prescription medications for safety reasons. So a follow-up question will be asked after each prescription is entered to know if there are any more medications to be entered, and the EDC will allow up to 10 prescription medications to be entered. Okay, maybe we should just take a pause right there really quick and see if there are any questions in the chat or anything. I haven't been monitoring it, so.
Yeah, there is one question from Marlena, and I'm not sure if you want to take it, Bethany or Brenna or someone else.
Yeah, can you just read it and we can answer it?
Oh, it was Marlena said, are we collecting what the parent and child identify as, or from what is in the medical record? I'm assuming this was about gender, so this is a way back.
Oh, good question. I believe that this is gender at birth. Does anyone? Oh, it's for race ethnicity. Race ethnicity.
Sorry, Marlena.
Okay, thank you for clarifying. I'm gonna let Ulrika answer this question. Actually, is that I would think that we're going to be first completing whatever we find in the EMR and then verifying that with the patient and updating it according to what they say is their ethnicity or race. Is that correct, Ulrika?
Yeah, that's what I would say too.
Okay, perfect. Good question. Are there any other questions? Okay, then we will move on. Okay, so the history of present illness form is important in determining the participant's previous Lyme exposure and also their current symptoms. There are responses on this form that will trigger questions in the daily survey, and it's extremely important that the form is completed on the same day as enrollment so that correct questions are asked on the daily surveys. If previous Lyme disease is known, please provide the year when it occurred. If a tick bite occurred in the last 6 months, be sure to provide how long ago. Measure the time in weeks. Approximate number of weeks is fine. Remember to complete this on day 0 when enrolling the participant. Okay. There we go. I'll make it something stopped my trigger. Okay. The question about the current illness are to find out if any of these symptoms were experienced at any time since the onset of the current illness, even if the symptoms have since resolved. So keep that in mind as this is being completed with the participant. So the pediatric Lyme meningitis symptom measurement form is collected at baseline and must be completed on day 0 because it's also part of the daily surveys that will be sent to the participants. And when the symptoms recover to mild or absent, the symptoms are considered resolved and the daily form will discontinue. So we do need this first one to be a part of that continuous record for determining symptom resolution. And the facial droop baseline measurement form needs to be completed for all participants at baseline, even if they have not experienced facial droop. Be sure to complete the history of present illness form prior to completing this form, because all the participants that experience facial palsy will need to complete the form, and it's indicated on that form whether or not there was ever facial palsy. If they experience facial palsy, then there will be a photo upload for this form, and that will be prompted in this form. A future, sorry, where did I go? And the forms will need to complete the form with the photo uploads, and photo uploads will be prompted even if facial droop has resolved, but future surveys will not continue to collect photos once the most recent survey indicates that the facial palsy symptoms are resolved. So even if they had it and it's been completely in remission before they actually are enrolled, make sure you get the photos showing that it's no longer present, and that will be sufficient. They won't ever have to upload any more photos. Any participants that do have facial palsy still need to have this form completed. When entering the form, the research coordinator can simply open the form, follow the written instructions, and mark it complete. No data entry will be required on this form when the participant did not experience facial palsy, other than to mark it complete as indicated in the form instructions. So this is what you'll see if there was no facial palsy. It'll just tell you mark it complete, but every patient does need to complete this form. So each upload will have a set of instructions and an image to illustrate what facial expression should be for that particular upload. Only one photo should be uploaded per question. Photo 1 collects a photo of the neutral expression of the face at rest. So I know Brenna went over these, so this is just a sample of what all those questions will look like. So moving on to file uploads. This study will allow for all file types, but JPEG and PNGs are recommended for images. In general, to utilize this tool, click on the Browse button to select a file for upload, and then click the blue Upload File button to upload this selection to REDCap. File uploads are an important tool used in this study, and the next few slides will discuss how to upload files and also how to upload photos from a mobile device. If a digital camera is being used, you'll want to take the picture with the camera and then upload to your desktop or laptop according to the instructions for your digital camera. And then click on the Upload File link. This will prompt a window to pop up where you will select to browse the computer. Click on the Browse button. Your next computer files will open and allow you to choose where you saved the pictures when you transferred them to the computer. After selecting your file, the name of your selection will appear next to the Browse button in the pop-up window so that you can confirm that you have selected the correct file. Once you have confirmed that the file is correct, click on the Upload File button to complete the upload. A new pop-up window will tell you when the file was successfully uploaded, and close this window to return to the form. So once a photo has been uploaded, it can still be easily changed. If for some reason you realize the photo uploaded is not correct, or you want to replace it with an updated photo, simply click on the Upload New Version link to open and browse the computer files. And you can also click the Remove File link to simply remove the current photo without replacing it immediately. Here's a quick summary of the steps for taking photos on an Android phone or an iPhone. and entering them into the survey directly. So then we'll review these step by step in the next few slides, but this is just a general reference for when you're referencing the slides, you just want a quick look at how to do it. So let's briefly run through the photo visuals of what to expect when taking photos directly from the camera on an Android or iPhone. Select the green upload file hyperlink with the upload icon to the left. So this is like when you're training them, they'll actually be taking the survey on their phone. And so in the survey on their phone, they'll just tap on that upload file hyperlink and it will come up on their phone. And this is what they'll see. And then select the choose file button. Notice to the left, it says no file chosen. And this way you can see that it is still waiting for you to choose a file to use. There's also a reminder that you cannot upload a file or photo greater than 32 megabytes. Select camera icon for Androids or the take photo or video link for iPhones. Frame the person's face in your camera's viewfinder and then press the camera shutter button as you normally would. If you are satisfied with the picture, press the camera shutter button, which now has a check mark in it for Android phones, or select use photo for iPhones. If you want to retake the picture, press the retake button, which has a sideways U-turn icon on it for Androids, or select retake for iPhones. You are now ready to upload your photo. Make sure that your photo was selected by checking for the file name to the right of the choose file. And this confirms that your photo is selected and ready to upload. Next, click the blue upload file button. File was successfully uploaded will pop up, and then select the close button to return to the form. Alternatively, you can take photos on your phone before entering the survey and then follow the same steps as before, only select photo library to access your photos that were previously taken, rather than taking them in the moment while you're completing the survey. You can select the photo from your photo library. Once the photo is selected, you can confirm the photo by clicking choose or select another photo by clicking cancel. Only forms that are set up to be surveys can access these survey options. So select survey options and a drop-down box can appear. Then scroll down and select compose survey invitation. So this is if you are needing to send the survey, like for some reason you're unable to access the photos because you're on the phone maybe while you're filling this out. And so you want to allow the participant to have access to this survey. You've partially completed it and now you want them to have access. So if you need to send the baseline form, that should be collected jointly with the participant and the RC. It makes more sense for the participant to upload these photos. The survey can be partially completed together and then sent in survey mode to the participant for further completion. Another use for the survey mode is if the participant reaches out and needs to re-access a survey to upload new photos or states that they haven't received their survey and needs another one sent. This is a quick solution for these types of scenarios. So you just click on the survey options and then put in, and then you can compose the survey invitation and have it sent directly to their email or text, whichever is recorded as the way it should be sent. Next, a screen will pop up that will allow you to customize and send an email or text message to the participant with a link to the survey. You will be allowed to select the type of message to send, at what time to send the message, and where to send the message. Once you've completed these options and customized the message appropriately, click Send Invitation. There are a couple of important things that you must remember when sending this link. One, the contact information page must be complete so that it knows where to send the text or email. And two, the link to the survey cannot be expired when you send the email. Otherwise, when they click on the link, they will receive a message informing them that they cannot, excuse me, they cannot access the survey because it has expired. So if this does happen, if you're trying to send a survey and it's expired and they tell you this, then you can contact the central RC team, whether that's Rhode Island Hospital or Boston, and ask them to extend the expiration to that particular survey. You can also contact one of the clinical data managers, myself or Tessa, and we can also help with this. Let them know the reasons for this request so that they can determine if the extension is appropriate, such as to upload a new photo that was missing or sent with errors. So those are probably the most common issues that will arise. Let's see, how are we doing on time? Okay, so let's just pause right there before we move on to the PedsQL surveys and see if there are any more questions. Oops, did I click something? Dang it. Chat, I guess there's none. Okay, sorry, I was clicking on the wrong thing there. All right, well, we'll keep going then. Baseline, this is the baseline PedsQL survey. The PedsQL form is collected at baseline, 6 weeks follow-up, and the 6-month follow-up. Each PedsQL survey is for a specific age range, and though the instructions for each age group is the same, the questions do vary slightly. So all questions will be divided into subcategories in the form layout. The survey should be taken when referencing the past week leading up to the survey. Here is a brief view of the form layout in their varying age groups. So note, this is just a sampling of the survey. Each survey realistically has about 20 to 30 questions, depending on the age group. The subcategories on each form is more or less to measure physical, emotional, behavioral, social, and cognitive abilities of the participant. Displayed first is the infant survey, ages 12 to 23 months of age. This is the toddler, ages 2 to 4 years of age. The young child, ages 5 to 7 years of age. The child, ages 8 to 12 years of age. The teen, ages 13 to 17. And the adult, ages 18 to 21. This is the treatment preference form. The first question asks how many treatment options were discussed at the visit. Depending on the response, the follow-up questions may vary. So if only one antibiotic was discussed, or if no options were discussed, or if the participant cannot recall, the survey will then continue forward with no additional questions. However, if the participant discussed multiple treatment options to follow, a follow-up question will be asked regarding the participant's treatment preference among the options discussed. The rest of the questions on the form will be asked to everybody. And this is a clinician assessment form. It will be best if the form is given to the clinician in a paper form and then later entered into REDCap by the RC. The form is divided into 2 portions: the physical exam. If the back of the eyes were examined, there is another question regarding the presence of papilledema, so just to be aware of that. And also the clinician's treatment preference is the other portion of this form. The daily and weekly surveys are the participant surveys and are key to the success of data collection in this study. It's important that the participants are committed to completing these surveys on a daily and weekly basis. The central RC team may contact your participants from time to time if surveys are missing or incomplete. And after the 6-week initial survey collection is complete, the participants is complete with the participants, the study will have a 6-week first endpoint follow-up and a 6-month final endpoint follow-up for the study. These surveys will be sent directly to the participants for completion. Additionally, there will be another 6-month endpoint survey to be completed by the RCs based on clinical records from the previous 6 months. And this form is still currently under development, but will be presented for training once it's ready. These are the safety forms that will be collected for this observational study. We have the protocol deviation form and the later found ineligible form. When a participant completes the study or stops participation for another reason, this form will be filled out with the date and the reason for discontinuation. If the study ends due to death or study withdrawal, be sure to include the date and the event and the date the event occurred. And remember to include comments to describe the reason for the final status. Okay. Well, thank you for watching the database training. If you have additional questions, then contact the study project manager, or clinical data manager, and I can review any questions you might have at this moment too.
Are there any questions for Bethany or Tessa at this point? Okay, please feel free to reach out to us if you have any additional questions. I just wanted to see if there's any other questions for Lise or Tom at this point, which we can answer.
I just want to say, this is Lise, and I just want to say thank you to all the sites that are doing their site workflow, their training, their IRBs, their contracting. We're really putting, a push through the end of this month to try to capture the end of this Lyme season and get a few enrollments at each site. So thank you very much. Reach out with any questions. Lyme meningitis, we really see it between May and October. So October's getting closer and closer, and we really want to get all sites active. So thank you.
Bob has a question.
Yeah. Hi, Lise. First, I was disappointed that you don't have a convertible.
I'm a minivan woman, Bob.
And Desi's on the call, I think, so she would know better than me. But we get the rapid ELISA test back within a couple hours. But we're not getting the Western blot back until the next day. Does that mean we're not going to be enrolling anybody in the ED?
Yeah, so your site is one of the modified 2-tier sites. So your first tier is an ELISA, and you are getting it back in a few hours. And if they go home before it's back, you can give them the patient information sheet. But before they can confirm eligibility, we need the second tier test, which for your site is also an ELISA test, but I do believe it takes another 24 hours. So if they're hospitalized, you may approach them, in the hospitalized. If they're at home, the consent may be done on the phone, and we have a verbal consent procedure in place.
But if their IgM is sky high, wouldn't that be good enough to, it just seems like a lot to do over the phone versus an ED.
Yeah, well, the first tier test being really high is very suggestive, but since our study is of patients with Lyme meningitis, we don't want to enroll anyone who isn't confirmed to have the disease on the confirmatory testing. And the CDC definition for Lyme meningitis requires both the first and the second tier test to be positive. I get your point, but we're just trying to be very specific.
That's fine. I just wanted to know the phone. Thanks.
Yeah, I just wanted to echo Lisa's thanks to the group for all your hard work. And we activated last week. We have the ability to screen in our adult ED, and the team has already seen a couple 18 to 21-year-olds who've gotten LPs. Turns out they weren't eligible, but it was still really exciting for them to be screening. And best of all, and shout out to Nicole Hins and the other folks from our team that are on the call. During this call, we had a patient with headache and facial droop and recent tick bite. So they got a patient enrollment information, a pre-enrollment patient information sheet before they left. So really exciting times.
That's very exciting. Well, if there's no other questions, then we will wrap it up and see you all on our next OSCE call, which I believe is in about 2 weeks from now. So in the meantime, if there's any other questions, just reach out to us. Thank you, everyone.